In terms of your playbook, because I feel like that might be the roadblock is the administration portion. Because I mean, I think most physicians we want our patients to not have a lot of pain. What were the compelling arguments to cover the cost? Because as of right now, 2024, it's not covered, but was it just the patient, the reduction in opioids?
That's one, and, you present them the data and you present them the studies, and then, the other thing that, as we all know, hospitals are very, very interested in and very serious about are their, patient satisfaction scores, right? So, when our GYN oncologist, presented, "Hey, look, these patients, they're very happy. They wanna come back to this hospital for their next surgery and come back to us for the next C-section," and, of course, that got their attention, because that's very important to them. The Press-Ganey scores, right? That's what they're called.
Yeah, I think women's health gets the short end of the stick a lot because Expir was used already in colon rectal at my hospital and general surgery at my hospital, and they were pushing back on the OBGYNs to use it. And it really took a champion, somebody to speak up to pharmacy because it comes out of the pharmacy's budget. And pharmacy, is all they care about is their budget. And we went to administration. We said, listen, women receive, I think it was 65% of all opioid prescriptions in this country. Because think about women's exposure to surgery early in reproductive years. Somebody has an ovarian cyst or a miscarriage or an ectopic or whatever. They have surgery in their 20s, and 40% of women are more likely to be persistent opioid users because of surgery, right? And surgery is painful, and you've got to cover that. So we really looked at women's health and looked at issues around surgery. I think it's 1 in every 15 people you operate on become chronic opioid users. There's 115 deaths every year in this country from opioid overdose. It's a gateway to other drugs. So there was all these issues around women's health. And women's health is important to the hospital because we all know women drive healthcare to what hospital you go to. You know what I mean? I mean, if the mom says, "Oh, my son's sick, take her to that hospital." You know what I mean? I had a great experience there. But the exposure in women's health to opioids is pretty high. And we were giving opioids, and then if you think about it, how many opioids do you really need after a hysterectomy? I mean, 10, 15, or whatever it is. Maybe some patients don't use them at all, and then they just have all this opioids hanging around the house. So when you talk to the pharmacy, he doesn't care about all that. He just cares about his budget. So we went to the nursing staff, we went to the administrators, at our OB/GYN departmental meetings, we have to present the No Pain Act. They don't really understand it or know that it's happening. So I think the real answer is having someone at the hospital who's a champion for women's health, somebody who's going to look at the data, speak up. We're not going to overuse it, misuse it. We're going to use it. Like I don't use it if I do a laparoscopic oophorectomy. I don't use it. I don't use Expir. But if you do a 3-port stage 4 endo case, you do a 4-port sacral colpopexy where there's a lot of torquing on the abdominal wall. There's a lot of surgical, work that you're doing. I think it's indicated, right? The profile, there's never been a death that I know of from Expir toxicity. If you look at the on-cue pump and the delivery of an analgesic in that arena, on-cue is another way to deliver an analgesic intra-abdominally. The plasma concentrations of bupivacaine are much higher than Expir. Expir peaks and comes down at 72, 96 hours. You have to get, I think it's 2,000 picograms per mil of Expir to see cardiac or central nervous system toxicity. So the profile is really low on side effects. So you have a drug that's effective. It has a low toxicity score. It decreases opioid exposure in women's health, which is what we all really care about. And yes, it's much more expensive than bupivacaine hydrochloride. But if you prevent one side effect of opioid and exposure, a dependency, nausea, lightheadedness, rectal impaction because of narcotics and low mobility, and all the things that happen. So you can justify it. And it really kind of makes sense that it is an effective analgesic that's going to increase your patient's experience at the hospital, decrease their exposure to opioids. The cost is worth it. We have to justify, risk benefit of everything. So I think that's how we approached it anyway.
Yeah, we were kind of the same way. We had a committee that got together and, it was headed by the GYN oncologist, but, you also have decrease in hospital stay usually if you have, less pain, less readmission rate, lower readmission rate, which is good for the hospital. And yeah, the toxicity, as long as it's used appropriately and it's, somebody who knows how to use it and how to admix it and they don't admix it, that with lidocaine or, there are some rules about that, then it's, yeah, I've never heard of anybody, having any kind of I've never had it toxicity from Expir on any patient. I don't know any colleagues that have. So it's very safe.
And then the other thing that just comes to mind is educating the nurses on the floor and having them know that this patient got Expir and nurses in recovery. Because if there is a patient who's not responding appropriate to voice commands, or she has CNS changes or cardiac changes, you want to know that patient got Expir because anything could happen, right? And then on the floor, if you're admitting the patient, the nurses need to know this patient got Expir. We're going to decrease narcotic use. Matter of fact, just give her Ofurmed or Motrin or maybe Tramadol, something like that. So it really is a team approach in trying to optimize this patient experience and reduction to opioids. And it seems to work. I mean, we transitioned from GYN only using it now to the OBs using it for C-sections. Everybody's kind of on board and we're not hearing any really backlash on calls and that sort of thing.
Just going to kind of piggyback on that with the nurses and it's a team effort, right? So, and with all the hospitals, most hospitals now have ERAS protocols and getting the Expir to be part of that ERAS protocol. So like Dr. McCarus said afterwards, most of my patients will just either get some Toradol or some, Tylenol with on top of their Expir because they've already, anesthesia is taking care of them during surgery. And then preoperatively, they've gotten their ERAS medications. And so it is a team effort. And as long as everybody's part of that, it really works well.